Hey guys, welcome to my channel. So today we will be talking about impaction. So it is a very important topic in oral surgery, and usually it comes as a 10 marker questions, but there are so many parts that can be asked inside this as a 3 marker or a 5 marker question also, right? So let's talk about indication of impactions. See, when you have to answer the question indications, you should not only just write the headings. You should also try to explain this a little bit possible, if possible, right? So the first indication that we are going to talk about is pericoronitis. See, when we talk about pericoronitis, this tooth, when it starts to erupt, the soft tissue that is present above it tends to get inflamed, and it causes a lot of pain. This pain is a reason that the patient comes to your clinic most of the times. So even if I am going to remove or cut this soft tissue, that by a procedure called operculectomy, it is going to regress back. So most of the clinicians think that removing the tooth is a good option. you know the second indication can be presence of caries. A lot of times the tooth that is impacted is found to be carious. It also causes caries to the adjacent tooth. And the presence of cyst is one of the most important reason of impaction surgeries, right? So this is a typical example of a dentigerous cyst. Okay, so these are the indications of impaction surgery. Next is a contraindication. See, the very important contraindication of this surgery is your uncontrolled diabetes. Diabetes is a very severe form of disease that is going to cause a lot of infections in the patients. So before you move on to any kind of surgery or maybe a simple extractions, you should always check the values of a patient's sugar level. Other contraindication is very old age. In very old age patients, the healing capacity of the patient is quite reduced, so it is very difficult for a patient of such age to cope up with the surgery. The other reason can be a presence of any kind of acute inflammation or acute abscess, right? So in the presence of acute inflammation and acute abscess, there's a lot of pain, and it is sometimes not advisable to do any kind of surgery under such conditions. Okay, so the next topic that we are going to talk is about classification. One very important thing that I forgot to tell you is whenever you are going to answer any question in oral surgery, there are 5 headings that you should always remember: indications, contraindications, classification, management, and complications. So we have already completed indication and contraindication, and now we are moving ahead with classification. Okay, so when we talk about classifications, there are many classifications given by the authors, but here we are going to talk about Winters and Pell and Gregory. So first, let's talk about Winters classification. In Winters classification, it is given according to the position of the impacted tooth in the jaw, right? So see, this is a mesioangular impaction. So it is bent towards mesially at an angle, so mesioangular. Similarly, distoangular, it is completely vertical, so vertical impaction, horizontal, so horizontal impaction. So it is a very easy classification according to the position of the impacted tooth and jaw, right? Let's move on to Pell and Gregory's classification. In Pell and Gregory, we have 2 classifications. First is according to the depth of the impacted tooth, right? So when we talk about the depth of the impacted tooth, see, this is your impacted tooth. So the occlusion line of this impacted tooth is in, and we have to check the reference from the adjacent second molar. So it is in line with the occlusion line of the adjacent molar also. So this is your level A, right? When we talk about level B, see, the occlusion line of the impacted tooth is below the occlusion line of second molar, but above the line of cervical line. So this is your level B. And when we talk about level C, it is at the level or below the cervical line, right? So at the level or below the cervical line. So this is your level C. Very easy. So you have to remember occlusion level of the impacted tooth and occlusion level of the adjacent tooth. So the second classification is according to the relation of impacted tooth with the ascending ramus. See, in class 1, you will see that there is a sufficient space to accommodate the entire tooth or accommodate the mesiodistal width of the impacted tooth. So this is your class 1. In class 2, we see that there is no sufficient space available, which means the space that is present is less than the mesiodistal width of the impacted tooth, right? And in class 3, we see that the entire tooth is embedded in the ramus. So class 3 is your embedded. So you have to remember the key points. Key point here is sufficient space available. Sufficient space less than the mesiodistal, and the tooth is completely embedded in the ramus. Okay, so let's move on to assessment. When we, before doing any kind of surgeries, it is very important to assess the clinical condition of the patient of the tooth properly. So the first thing is you're going to take a proper history. After the history, you have to do certain local examinations. Presence of any kind of acute abscess. Then IUPA is not a standard a radiograph that is prescribed here. You have to go for an OPG. After the OPG, you have to assess. So how are you going to assess? There are certain assessment or difficulty indexes. Like here is your Warts assessment and this is your Peterson's assessment. Right. So using these kind of assessment indexes, you're going to find out the difficulty level of the surgery that you are going to perform. Right. And after that, there's a very important topic or a very important thing that you have to remember under assessment is your war lines. So this is your white line, this is your amber, and this is your red. Right? So this white line basically represents the occlusion level of the tooth or the occlusion level of the impacted tooth and in reference to the adjacent tooth. You should always have a reference. So the reference is your adjacent tooth. Then we talk about the amber. Amber is basically the bone that is covering this tooth. Or let's just say how much bone is supposed to be removed in order to find a point where you can, you will be able to luxate it. And the red line is the depth of the tooth. Okay, so it's quite easy. You have to just remember white line depicts your occlusion level, amber lines, it represents your bone that is covering the tooth, and red line is your depth. Lastly, under this topic comes your relation with the inferior alveolar nerve. So, this we particularly talk when you're treating any mandibular third molar. So, you have to assess the relationship of inferior alveolar nerve and the molar, because sometimes what happens when after we perform the surgery, the patient might go under complete stage of anesthesia or sometimes paresthesia also. So, in this condition, you are supposed to take a proper informed consent from the patient. Right? Okay. Next stage that we're going to talk is management. So there are certain headings under management that you're supposed to remember. See, the first thing is your anesthesia. Okay. So before that, sterilization has to be maintained. Patient should be painted with betadine, and a proper drape should be given to the patient. After which you can go for any kind of anesthetic block. Maybe mandibular or maybe inferior alveolar. Okay, and maybe PSA if you're treating a maxillary, tooth. And then we go for incision and flaps. See, the particular incision that we are looking forward to is your Warts incision and modified Warts. So what is a Warts incision? You start from your ramus part, come down to the distal side of your impacted tooth, give a clavicular incision here, and then a vertical incision downwards. So this vertical incision, it begins from the distal aspect of your second molar. But in your modified Warts incision, the vertical incision is from your distal aspect of first molar. So this is a basic difference in Warts incision and a modified Warts incision. So when we talk about flap, you can go in for an envelope flap. It is generally seen in your maxillary cases and it has 0 vertical incision. Whereas this is your L-shaped flap. it has one vertical incision, and when you reflect this flap, it is going to be reflected like this in an L shape. So that is the particular reason that we call it as L shaped flap, right? Okay. Next is your removal of bone. So when you remove the bone, what is that you need to keep in mind? See, you have to remember that you are not going to remove the bone in an extensive manner. It is going to cause a lot of inflammation. Apart from that, till what level should the bone be, removed? So you have to always remember that if this is your tooth, you have to go below this contour line. Because below this contour is a point where you will get a point of luxation, where you will be able to remove this tooth. Okay, so let's talk about techniques. So initially we used to have only chisel and mallet, but now we also have osteotomy burrs. So osteotomy burr and handpiece. Okay, this is a quite old technique. This is what we use nowadays, but this is definitely more safer, but takes a lot of time. And this, it can cause complications like emphysema. Emphysema is basically, accumulation of air or air bubbles, while you will be cutting the bone, right? So the first technique that we are going to talk is about Moore and Gilb's collar technique. It is a very conventional technique and a very easy. In this, we are going to use a number 3 rose head burr, right? Number 3 rose head burr is going to be used. So what you are going to do is, on the buccal side, you are going to remove the bone, little bit on buccal and distal. So you're going to create a gutter. See, this is a tooth and this is the bone. So you're going to remove this and form a gutter on buccal and distal aspect. Then you're going to reach below the contour point, where you will find a point that can be used as a point of luxation. Okay. Next is your lingual split technique of bone removal. This is also called as Kelsey Fry technique. Okay. In this, you use chisel and mallet. First up, what we do is we create a vertical stop on the distal side of your second molar, and then you use a chisel facing upward, and then make a horizontal cut from backwards till this vertical point. So if this is your vertical point, you're going to make a horizontal cut like this, and then this entire buccal bone plate is going to be removed. After you remove this, there will be you will have bone plate on your lingual side. So you are going to place a chisel here, and then you are going to break this lingual bone inwards, right? After which only a very little part of bone will be remaining somewhere distal to the tooth, and then after removing that, you are going to remove the tooth completely, right? So after you remove the bone, you are going to remove the tooth. So tooth removal can be easy, or you have to do odontotomy. It is a technique which was given by Hayat, where you do odontotomy. So you're going to divide it like 1, then 2, and then 3. This is the kind of dissection as you're going to do. 1, 2, and 3. And remove the tooth in pieces, right? So the next thing is wound debridement. So after you have removed the tooth completely, you're going to debride the socket, use a curettage maybe to curate the socket, and then use betadine irrigation, attain a proper set of hemorrhage. After that, you're going to place sutures and close the socket, and give post-operative instructions to the patients. Now, in post-operative instructions, it is very important that the most important instruction is advising warm saline rinse. And there are certain other instructions like medicines and medications. So you have to remember that thing in your mind. After you complete the management, the last topic that I think we need to know is complications. So complications has 2 parts. First is your complication while you are performing the procedure, and then complication after the procedure has been done. That is post-op. Right. So while you're performing the procedures, there can be injury to viable structures, like you can cut any artery, or maybe you have when you're placing the incisions have not been placed properly, so this can compromise healing. And then definitely present this emphysema during the bone reduction, and of course nerve injury, mainly IANV, that is inferior alveolar nerve block. Sorry, nerve, not B. I'm used to writing it as I and B. What we are talking here is inferior alveolar nerve. So in post-op complications, these can be your immediate ones, and these are your delayed ones. Immediate can be, secondary hemorrhage. Like you have already attained hemorrhage, but again it starts bleeding. Or there can be pain, there can be edema and swelling. And due to this edema and swelling, a delayed complication can be trismus. One very important delayed complication is your alveolitis. Alveolitis is your dry socket. This is a very important topic. I will be dealing with this topic again when I will be talking about exodontia. And apart from that, patient can also develop any kind of infection. Infection generally occurs when the patient has uncontrolled diabetes. So that is one reason that we should always have a look on patient's sugar level before we proceed with any kind of surgery. Let it be a simple exodontia also, right? So I think this will be it for today's lecture. So guys, if you like the video, please like it, subscribe it, and share as much as possible. I've tried to present this topic in a very simple manner in front of you, so that you can just simply write in your question papers. Okay, so meet you next time. Bye.